Very good evening, all our viewers today on the Facebook channel of Khushhi IVF. Khushhi IVF is celebrating every year World Infertility Week the same time to create awareness amongst infertile couples and give them the maximum benefit of conceiving and having a healthy family. Today we have with us Dr. Shilpa GV, who is a famous gynecologist, and we have Dr. Dipesh, whom our viewers already know. Dr. Shilpa, on behalf of Dr. Dipesh and Khushhi IVF team, we heartily welcome you on this channel and thank you for giving us this amazing time and your insights on the upcoming topic, that is endometriosis.
Thank you.
Right. So to start with the session, my first question goes to Dr. Dipesh. Dr. Dipesh, can you just define endometriosis for our viewers?
So, endometriosis is a condition where the normal menstruating endometrium is not in the uterus. We call as a uterine lining that is outside of uterus, like in ovary or in uterine wall or in the pelvis or in the abdominal wall, or there are the various places where you can find the endometriosis. So another ectopic place of endometrium that called in the scientific language, I say ગુજરાતીમાં કહીએ તો જ્યારે ગર્ભાશયની દિવાલ જે દર પીરિયડ્સમાં બહાર આવે છે એ અંડાશયમાં હોય, અંદર નીચેની જગ્યાએ હોય, ગર્ભાશયની દિવાલમાં હોય, એબ્ડોમિનલની વોલ થિકનેસમાં હોય, આ બધી વસ્તુમાં જ્યારે ગર્ભાશયની દિવાલ એક્ટિવ હોય એને endometriosis કહેવાય છે.
Right. So, Dr. Shilpa, how endometriosis is causing problems in females? What kind of problems does it cause to them?
So usually endometriosis is a very debilitating disease. मतलब उसमें बहुत सारे problems आते हैं. ये कोई भी एज में भी आ सकता है ये प्रॉब्लम. So it can come either in college going girls, or it is in newly married couple, or it can come even after the age of 35 to 40 years. So this endometriosis, usually they present with problem of pain in the abdomen during the periods. So the pain can be only on the first 2-3 days of the periods, or it can start just before the periods and it can last for 4 to 5 days throughout the periods. And this pain becomes more and more as the months go by. So last year it may be just for 1 or 2 days. Then this year it may increase to 3 or 4 days. And the pain would have come down with 1 tablet in the last year. But now she will require 4-5 tablets to control the pain. So it is progressive. मतलब वो ज़्यादा ही होता जाता है. और इसमें फर्टिलिटी का मेन इश्यूज रहते हैं. मतलब जब ये कपल ट्राई करते हैं प्रेगनेंसी के लिए, तो तब वो कंसीव होने में थोड़ा दिक्कत हो सकता है इनको. तो ये ओवरीज में सिस्ट बना सकते हैं, या ट्यूब में ब्लॉकेज बना सकते हैं, या यूट्रस में वो केमिकल्स रिलीज करके इम्प्लांटेशन का प्रॉब्लम भी हो सकता है इसमें. और बाकी मतलब 40 इयर्स के बाद ये ब्लीडिंग का इश्यूज भी हो सकता है. जो मेंस्ट्रुएशन 8 दिन से ज्यादा वो रहेगा ब्लीडिंग, और ज्यादा ब्लीडिंग होगा. और वो उसके टाइम में क्लॉट्स, मतलब वो जो बड़े बड़े क्लॉट्स गिरते हैं वो भी ज्यादा होने लगेंगे. इससे इन पेशेंट का हीमोग्लोबिन भी कम हो सकता है. सो ऑल दीज थिंग्स आर common complaints of endometriosis. Sometimes it could be in the bladder, bowel, which can again cause problems of the urination and motion.
Right. It was very insightful, Dr. Shilpa. Dr. Dipesh, we would also like to take this talk forward now and understand from you that how the endometriosis, madam just mentioned that endometriosis, every coming period, it would go severe and severe and severe. So how do you medically manage endometriosis, sir?
So जब भी कोई फीमेल कपल आता है with when on the examination or investigation we diagnose the endometriosis, तो दो चीजें बहुत ध्यान रख के हम लोग काम करते हैं। एक तो कि उनको फर्टिलिटी चाहिए या दे जस्ट कम फॉर द एंडोमेट्रियोसिस पेन। सो पेन के लिए आए हैं सिर्फ, तो उसका मेडिकल मैनेजमेंट इज वेरी डिफरेंट। फर्टिलिटी के लिए आते हैं तो उसका मेडिकल मैनेजमेंट कभी नहीं होता, क्योंकि फर्टिलिटी जो मेडिकल मैनेजमेंट्स होता है यूजुअली दे आर द हार्मोनल मेडिसिन, कि भाई उनका टेम्परेरी पीरियड बंद हो जाए या हार्मोनली कुछ मेनोपॉज जैसा स्टेट क्रिएट हो जाए, कि जिसकी वजह से जो एंडोमेट्रियोटिक जो लीजन से जो हार्मोनली एक्टिव है वो थोड़ा टाइम काम करना बंद कर देंगे। और पेन के लिए पेन किलर्स जो होती है दैट विल हेल्प फॉर देम, बट फॉर फर्टिलिटी पॉइंट ऑफ व्यू यूजुअली कोई मेडिकल मैनेजमेंट इज नॉट देयर।
Right. Dr. Shilpa, what causes endometriosis in females?
So the actual reason for endometriosis is still not known. तो कभी बोलते थे पहले कि जो पीरियड्स वो बाहर निकलता है तो वो वापस रेट्रोगेट, मतलब वो अंदर ट्यूब में अंदर वो पेशेंट के एब्डोमेन में वापस जाके उधर ये एंडोमेट्रियल सेल्स डिपॉजिट हो जाते हैं और उससे ये एंडोमेट्रियोसिस का सेल्स जो है वो एक्टिव, एंडोमेट्रियम का सेल्स जो है वो एक्टिव होके जब भी पेशेंट को मेंस्ट्रुएशन ब्लीडिंग आता है पीरियड्स में, तो उसी टाइम पे जो अंदर भी वो स्पॉट्स है उधर भी ब्लीडिंग होने का चांस रहता है और ऐसे ही वो फैलता जाता है। लेकिन उसका थ्योरी के लिए मतलब कोई प्रूफ नहीं है कि वो रीजन वही है। सो वी डोंट नो एक्चुअली व्हाट इज द रीजन फॉर दिस एंडोमेट्रियोसिस and I think we should stop looking for a reason. So there are families where every woman will suffer with endometriosis. So sometimes we say that it could be genetic also, and in some cases where we expect that there could be endometriosis, there will be nothing there. So the reason still is unclear, and rather than looking for the reason, I think we should counsel the patient as to how we should treat it and how we should make her pain free, how we should make her better.
Right. So today even the reasons of endometriosis are not known, and that is really unfortunate. And rather than looking and digging into, as rightly said by ma'am, we should look into how we can make the patients more pain-free and live a pain-free life. We'll take this talk forward, and now I'll ask Dr. Dipesh that are there any types of endometriosis, or are there any different sizes which needs different management?
Yes. So आपका जो पहले का क्वेश्चन था कि मेडिकल मैनेजमेंट, so medical management have the very limited role in the endometriosis. के भाई stage 1 or stage 2, usually these stages are the diagnosed when any couple is going for the laparoscopy की और MRI, उससे उसका grading decide होता है. So medical management has a very limited role for the earlier endometriosis. जो आपने पूछा है कि क्या आगे उससे ट्रीटमेंट रिलेटेड क्या इश्यूज हो सकते हैं। सो जैसे बताया कि एंडोमेट्रियोसिस के डिफरेंट टाइप, जो कभी बोवेल, जैसे डॉक्टर शिल्पा ने बताया, कभी यूरिनरी। नॉर्मली एंडोमेट्रियोसिस 2-3 जगह पे होता है। ओवरीज में होता है, जिसको हम हमारी लैंग्वेज में चॉकलेट सिस्ट बोला जाता है। इट इज वेरी कॉमन टर्मिनोलॉजी के, आपको सिस्ट है, उसमें ब्लड भर गया है और वो ब्लड का कलर चॉकलेट जैसा होता है, फॉर दैट कॉल एज ए चॉकलेट सिस्ट। इट इज कॉमनेस्ट थिंग। दोनों साइड की ओवरीज में भी हो सकता है। यूट्रस की वॉल में होता है, आइदर स्मॉल आइसोलेटेड होता है या पूरे यूट्रस में होता है, जिसको हमारी लैंग्वेज में एडिनोमायोसिस बोला जाता है। थर्ड, जो पेल्विक ऑर्गन्स होते हैं यूट्रस के पीछे, बोवेल के बीच में होता है, उसको हम लोग पेल्विक एंडोमेट्रियोसिस बोलते हैं। जैसे मैडम ने बताया कि बॉवेल में भी होता है, इंटेस्टाइन में भी होता है, ब्लैडर में भी होता है. Recently, Dr. Jay, who is the part of panel not able to join, he found near the liver endometriosis. Abdominal wall में भी होता है. किस लोगों का जिनका नॉर्मल डिलीवरी हुआ है उनको एपिजोटोमी करके एक प्रोसीजर होता है, वहाँ पे भी सर्जिकल साइड में भी एंडोमेट्रोसिस we have found, and we have operated many cases. Dr. Shilpa has also operated many cases. Dr. Jay has operated many cases. We have operated. So anywhere we can find the endometriosis.
Right. So, thank you, Dr. Dipesh. So, as a layman, I understand that if endometriosis is not taken care earlier, it is only going to go severe. Correct me if I'm wrong, Dr. Shilpa.
Yes, no, it is correct.
Right. So, as we go for, as the patient starts ignoring the surgical intervention, it only goes severe and severe, and it may spread to other organs of the body. Dr. Shilpa, what could be the size of the endometriosis which needs surgical intervention?
See, as Dr. Dipesh said, there are two types of endometriosis mainly, typical and atypical. Typical is like which is commonly seen. मतलब वो जो बहुत सारे women में common से हमको वो diagnosis मिलता है, उसमें क्या है, ओवरी में इन्वॉल्वमेंट रहता है और थोड़ा बहुत वो ट्यूब में और यूट्रस में थोड़ा इन्वॉल्वमेंट रहता है. एक कॉमनेस्ट है, ये इसको हम टिपिकल बोलते हैं. और ये साइज का जो भी है वो हम टिपिकल एंडोमेट्रियोसिस में ही बात करते हैं. मतलब जो ओवरी में वो सिस्ट, चॉकलेट सिस्ट जो है, उसका ही हम ट्रीटमेंट साइज के हिसाब से वो डिसाइड करते हैं. तो यूजुअली क्या होता है, दो टाइप्स के पेशेंट्स रहते हैं. एक जिनमें साइज इतना बड़ा नहीं रहता है लेकिन बहुत सिम्टम्स रहते हैं, और दूसरे टाइप के पेशेंट्स जो रहते हैं उनमें बहुत बड़ा सिस्ट रहता है लेकिन उसमें कुछ सिम्टम्स नहीं रहते हैं. तो वी हैव टू take a balance of the patient's symptoms and also what we find in the ultrasound scanning report. तो अगर वो साइज बहुत कम है लेकिन पेशेंट को बहुत ज्यादा प्रॉब्लम है, मतलब पेन वो 4-5 दिन रहता है, उनको इतना सिवियर पेन रहता है कि वो पेन किलर्स से भी वो पेन नहीं कम होता है, या फर्टिलिटी में वो सब ट्रीटमेंट ट्राई कर चुके हैं लेकिन कुछ भी उनको ट्रीटमेंट सक्सेस नहीं हो रहा है, ऐसा है तो जो भी साइज का है वो हम ऑपरेट करते हैं. लेकिन कुछ भी सिम्टम्स नहीं है, फिर भी हमने सिर्फ स्कैनिंग में जो वो हेल्थ चेकअप के लिए आए तब हमने डायग्नोज किया है, तो उनको हम बोलते हैं कि 5-6 सेंटीमीटर से ज्यादा है तो ही उसको ऑपरेट करना है, नहीं तो उसको फॉलोअप करना है हर 3 मंथ्स और या हर 6 मंथ्स में. अगर वो साइज बढ़ रहा है तो ऑपरेट करना पड़ेगा. अगर वो फर्टिलिटी का ही इश्यू है तो फर्टिलिटी में हम 3 सेंटीमीटर्स भी एक बार बोलते हैं कि विथ 3 सेंटीमीटर सिस्ट, अगर उससे बड़ा है तो हमको सर्जरी करके ही वो बाकी का IUI या IVF जो भी है वो ट्रीटमेंट चालू करना है. अगर वो 3 सेंटीमीटर से कम है तो उनको कुछ नहीं करना है ये सिस्ट के सर्जरी का, वो डायरेक्टली ट्रीटमेंट के लिए जा सकते हैं.
Right, ma'am. Ma'am, going forward to this diagnosis of endometriosis, you just mentioned that during the scan, we get to know that what type of endometriosis, what size of endometriosis, what are the symptoms. Patient would also like to come and understand that will the simple scan talk about the exact, status of the disease, or are there any other diagnosis also which needs to be considered?
See, the main diagnosis modality nowadays, or I think which has been there from past couple of years, has been only ultrasound. That is the transvaginal ultrasound. जो इंटरनल स्कैनिंग हम बोलते हैं उसको हम इंटरनली, मतलब वेजाइना से जो प्रोब वो रहता है उसको इंसर्ट करके हम स्कैनिंग निकालते हैं. तो दिस इज द मोस्ट एक्यूरेट मोडालिटी टू डायग्नोज एंडोमेट्रियोसिस और चॉकलेट सिस्ट. एंड अभी ये जो अल्ट्रासाउंड के मशीन है अभी इतना एडवांस हो चुका है कि हम परफेक्टली बता सकते हैं कि वो एंडोमेट्रियोसिस कहाँ पे है, वो इंटेस्टाइन्स को इन्वॉल्वमेंट हुआ है नहीं, ब्लैडर का इन्वॉल्वमेंट हुआ है नहीं, या कौन से इन्वॉल्व मतलब वो ब्लैडर में कितना साइज का इन्वॉल्वमेंट है, बवल में कितना वो पेनिट्रेट हो चुका है, वो सब हम ये अल्ट्रासाउंड से ही पता कर सकते हैं। लेकिन खाली ये है कि वो जो करते हैं अल्ट्रासाउंड, जो डॉक्टर वो करते हैं अल्ट्रासाउंड, उनका ट्रेनिंग बराबर से होना है। तो उनको एक्सपीरियंस रहना है कि ऐसे केसेस में स्कैनिंग करने का, और उनको मतलब उनको बोलना है जो भी सर्जरी करने वाले हैं कि ऐसा ऐसा है हमारा फाइंडिंग्स, तो आपको ये जगह पे वो एंडोमेट्रियोसिस मिल सकता है। तो स्कैनिंग जो डॉक्टर करते हैं, सर्जरी जो डॉक्टर करते हैं, उनके बीच में बराबर से पहले डिस्कशन होने के बाद ही हम सर्जरी या कोई भी ट्रीटमेंट हम प्लान कर, या फर्टिलिटी स्पेशलिस्ट, सो सब में अगर हम इंटर डिस्कशंस वो सब हुआ तो पेशेंट का रिजल्ट्स जो है वो बहुत अच्छे रहते हैं।
Right, ma'am. Ma'am, going further to this, lot of patients come to us and ask us that if it is an open surgery done, probably endometriosis can be cured in more accurate than when it is done endoscopically. So what are your views on that?
एक्चुअली इट इज अ रॉन्ग व्यू, बिकॉज जो ओपन में जो हमको विजन जो दिखता है वो इतना बराबर से नहीं दिखता है, क्योंकि ओपन में जो है वो इंटेस्टाइन्स रहते हैं, पेल्विस थोड़ा डीप रहता है, उसमें हम हाथ डाल के वो लाइटिंग उधर तक नहीं जाता है ओपन सर्जरीज में, तो उसमें क्लियरेंस अच्छे तरह से नहीं होगा। और जो एंडोमेट्रियोसिस का जो प्रॉब्लम है वो उधर सब चिपका रहता है, इंटेस्टाइन चिपकता है, ब्लैडर चिपकता है, ट्यूब्स, ओवरीज, मतलब क्या कौन सा क्या ऑर्गन है वो मालूम ही नहीं पड़ता है, इतना तक सीवियर रहता है। तो बेस्ट है लैप्रोस्कोपी से ही करना, क्योंकि लैप्रोस्कोपी में वो मैग्निफिकेशन मतलब जो 1 सेंटीमीटर का है वो बड़ा दिखता है, 4 सेंटीमीटर का दिखेगा। तो उसमें जो मैग्नीफाई होके वो दिखता है, उसमें हमको इजी रहता है कि कहाँ कौन सा एरिया में वो चिपका है, कैसे उसको डिसेक्शन करना है, कैसे उसको निकालना है, वो सब लैप्रोस्कोपी में इजी रहता है। लेकिन लैप्रोस्कोपी जो करने वाले हैं उनको एक्सपीरियंस होना है ऐसे तरह के सर्जरीज करने में, तभी उनका जो सर्जरी वो होता है वो सक्सेस होने का चांस ज्यादा रहता है। नहीं तो लैप्रोस्कोपी करो या ओपन सर्जरी करो, अगर वो एंडोमेट्रियोसिस में एक्सपीरियंस नहीं है तो वो आधा आधा ही होगा और वो फिर से वापस आ जाएगा एंडोमेट्रियोसिस।
Right. Ma'am, you just talked about the success of the surgery. How is success defined in an endometriosis surgery?
See, in endometriosis, we take 3 points. One is मतलब उनका जो सिम्टम्स है, क्वालिटी ऑफ लाइफ हम जो बोलते हैं, मतलब जो वो जिंदगी जी रहे हैं अभी, तो वो कितने कंफर्टेबली जी सकते हैं। तो अगर उनका पेन स्केल जो स्केल बोलते हैं 10 नंबर है, तो 10 में उनका पेन जो 8 या 9 नंबर है, वो सर्जरी के बाद कितना कम होगा। तो अगर वो 2 या 3 नंबर में आ जाएगा तो हमारा सर्जरी यस इट्स वेरी गुड। तो दूसरा है उनका फर्टिलिटी। फर्टिलिटी अगर हम उनका हेल्प करते हैं फर्टिलिटी बढ़ाने में, मतलब जो भी चिपका है उसको रिलीज करते हैं, ट्यूब अगर ब्लॉक है तो ट्यूब को थोड़ा ओपन करते हैं, ओवरीज अगर चिपका है तो उसको रिलीज करते हैं, अगर ये सब करते हैं तो उसमें अगेन इट विल बी मोर सक्सेसफुल। सो थर्ड थिंग रहता है वो रेकरेंस, मतलब उसको वापस फिर से नहीं आना है। तो अगर हम उसको मैनेज करेंगे तो ये तीनों पॉइंट्स में सबसे आई थिंक ऑल द 3 आर इक्वल इम्पोर्टेंट। तो रेकरेंस नहीं होना है, मतलब एक बार सर्जरी किया तो वो परफेक्ट सर्जरी होना है, उनको फिर से ये सिस्ट का प्रॉब्लम नहीं आना है। तो ये तीनों हमको बैलेंस करके करना है, तभी हम बोलते हैं कि सर्जरी सक्सेसफुल है।
Right. So, ma'am, let's go deep dive into these three things that you have mentioned. Most of the patients come back to us and say that, I got my surgery done, right? But still I have pain. So the surgery is not successful. This is one thing that they say, and that is how it affects their mental status also, that I would have to again go for a resurgery. Then will it further, lower down my pain? And third is whether it has, what are the chances of recurrence? And thinking in all these 3 aspects, the patient who have got a second surgery done, would now again think that, I don't want to even go for a second surgery because I may undergo a third surgery as well. So what is your viewpoint on this?
So I think the most important thing here is like, the patient gets very frustrated when the recurrence happens. और पेशेंट को क्या होता है, उनको ये ट्रस्ट जो रहता है वो खत्म हो जाता है डॉक्टर के बारे में. वो जितना भी हमको ये करो, ये सही नहीं होगा, हमको जिंदगी भर ऐसे ही रहना है, तो हमको क्यों सर्जरी करना, क्योंकि एक बार किया फिर से आ गया, तो पेन भी ऐसा ही है, तो कुछ फर्क नहीं पड़ेगा, क्यों सर्जरी, बार बार सर्जरी करना, बार बार पैसे खर्च करना, ऐसे उनका थॉट प्रोसेस वो चालू हो जाता है. But it's very, very important for us to counsel them and tell them that if the surgery is done at the right time by the right person at the right with the right facility, then the recurrence chance will be less than 3%. 3% से कम होता है recurrence. तो फर्स्ट सर्जरी जो रहता है वो बेस्ट सर्जरी रहता है. तो बार बार वो करने से ऐसा नहीं है कि सेकंड सर्जरी में और अच्छा क्लियरेंस होगा, थर्ड सर्जरी में सेकंड से भी ज्यादा अच्छा रहेगा, ऐसा नहीं है. So the first surgery is the best surgery. So we have to aim at clearing it up in the first surgery itself, and it is the duty of the person who is seeing that patient to send the patient or to get the help of a good laparoscopic surgeon who can do a best job at that time. ऐसा नहीं है कि वो हमको भी आता है चलो करते हैं, ऐसा नहीं करना है, क्योंकि हमारा जो एम रहता है वो पेशेंट का the best treatment possible जो रहता है वो देना है.
Right. Got your point very nicely guided, ma'am. And if it is done by the right person, that's what I understand from the patient's perspective, that if it is done by the right surgeon and by the right method, the recurrence rate is 3%, and that's where we can address the frustrations of a patient and increase their trust on surgeons.
Correct.
Right. Coming to the fertility part of it, Dr. Dipesh, please help our patients understand that how endometriosis is a major hindrance for conceiving.
So if कोई भी couple फीमेल जो एंडोमेट्रोसिस से है, तो यूजुअली जैसे हमने लोकेशंस बताए कि मेनली कॉमन लोकेशंस टिपिकली ओवरीज में होता है. तो व्हेन देयर इज अ एंडोमेट्रोसिस सिस्ट इन द ओवरी, तो इट damage the healthier part of the ovary, and that reduce the ovarian reserve of that patient. So by that, it's reduced the ovarian reserve. It causes the bad quality of eggs. Second, pelvic में है endometriosis, ट्यूब्स के आजू बाजू है, तो that causes lot of adhesions, यानी चिपक जाता है सब कुछ. Third, it creates a certain toxins that have the normal fertilizing process and that have the hamper. Fourth, जैसे यूट्रस में एंडोमेट्रोसिस यूट्राइन वॉल पे होता है, जो हम लोग एडिनोमेट्रिक बोलते हैं. If this type of endometriosis, it's reduced the implantation rate practically. So there are a lot of mechanisms that depending on the site situation play in the infertility reasons. So mainly this endometriosis chocolate cysts are there, very bigger cysts. They damage the healthier part of the ovaries. So whatever the ovarian reserves go down, but and then the normal typically patient doesn't conceive. Like if we found the grade 3 endometriosis or grade 4 endometriosis, they are the patients for the IVF usually. For grade 1 and grade 2 patients, after the surgery, they can go for the IUI treatment, or if later on, if required, for the further treatment. So, right, Dr. Shilpa has told us that proper surgery is needed. So, if any patient is going for the fertility, looking at the fertility preservation surgery for the endometriosis, the good surgeon, complete clearance, and the timely treatment after that surgery, it's important to prevent the recurrence. कुछ पेशेंट्स ऐसे होते हैं जो सर्जरी करवा लेते हैं, उनको ऐसा होता है कि नहीं अभी तो एंडोमेट्रोसिस गया, फिर they come after 2 years and again we find that भाई आपको तो चॉकलेट फिर से हो गया है. So when we ask that कि आपको क्या बोला था, नहीं सर हमको तो बोला था you try naturally, everything is fine, you get the pregnancy in the future, नहीं हुआ इसलिए अभी आए. So counseling before the endometriosis surgery, whether you go for the fertility preservation, especially when we are for the infertility reason, it's most important part, and the right person, right clearance, this is more important.
Right. Thank you, sir. Dr. Shilpa, we would also like to know the advantages of a laparoscopic surgery.
See, laparoscopic surgery, it is a one-shot treatment, as in like if the patient comes for the surgery, so majority of her problems can be solved in that one surgery. Second thing is the laparoscopy will give us also an idea about where else the disease is, which can be missed in ultrasound. So we can pick up the problems which are the disease which is there in other organs also, and we can treat it at the same time. So
Right.
the third thing is like the cost, though we consider that in the surgery the costing will be more, but the other medical treatment like lupride injections or Dianoges, whatever is there, if we think of the costing over the 3 years or 5 years, it will be almost 2 times or 3 times of the surgery if you look at it that way. And also that is a temporary treatment option, the tablets and injections that they take. So while they are on the medicine, they will feel good. Once they come out of those medicines, the problem will come back. But in surgery, it is like, one shot treatment where the side effects of the medicines can be avoided. They can get back to their work. They can be completely mentally free of this problem. And also their symptoms will be really like quite better if it is done in the right way.
Right. Now, when the patient is ready for the surgery, what precautions should a patient take before the procedure and after the procedure?
So before the procedure, see, first thing is we need to know what is her main complaint. Is it fertility? Is it pain? So, or is it both? So if it is only fertility, then we have to strike a balance between conserving the eggs and also giving the right amount of clearance. If it is pain and fertility both, then we have to make sure that the endometriotic nodules, or if there are anything apart from the cyst in the ovary, then we have to give a good clearance for that. So first thing is we need to know what the patient has come for. And before the surgery, if it is for fertility, then we need to make sure that her AMH, that is her blood test, which will tell us about the number of eggs in her. तो जितना कितना अंडा है अभी उनके ओवरीज में, उसको चेक करना है. और दूसरा है OCA 125 करके एक ब्लड टेस्ट करते हैं. उसमें क्या मिलता है, वो पेरिटोनियम, मतलब जो लेयर, वो लाइनिंग रहता है ओवरीज पे, यूट्रस पे, वो लाइनिंग में ऐसे ऐसे स्पॉट्स वो है या नहीं. अगर है तो ये CA 125 का लेवल्स थोड़ा ज्यादा रहेगा. अगर ये ज्यादा है तो वो लेयर को निकालना पड़ेगा ताकि वो रिकरेंस ना हो पाए. तो ये सब हम पहले ही पेशेंट को बता देते हैं. और अगर पेशेंट का ओवरी निकालना है, ट्यूब निकालना है, जो भी है, उनको पहले से ही वो हम प्रिपेयर कर देते हैं बिफोर द सर्जरी, सो दैट द पेशेंट इज नॉट सरप्राइज्ड ड्यूरिंग द सर्जरी. और ये सब क्लियरेंस के बाद पोस्ट ऑपरेटिव में जो भी हम सर्जरी के टाइम में हमने देखा है वो अंदर कैसा है, क्या है, उसके हिसाब से हम फर्टिलिटी ट्रीटमेंट का प्लानिंग बनाते हैं ड्यूरिंग द सर्जरी और जस्ट इमीडिएटली आफ्टर द सर्जरी. So it's very, very important for the patient to know that fertility treatment has to start immediately after the surgery. This is the most important point. So patients के क्या समझते हैं, वो हमने इतना खर्चा कर दिया है अभी सर्जरी का, तो हम आते हैं 3-4 साल बाद हम पैसे जोड़ के आते हैं, नहीं तो सर्जरी हुआ है अपने आप से हो जाएगा प्रेगनेंसी. तो ये जो वो सोचते हैं वो रॉन्ग है. तो सर्जरी के पहले ही हमको पेशेंट को वो अलर्ट कर देना है कि उनका ट्रीटमेंट जो है इमीडिएटली आफ्टर द सर्जरी चालू करना है. वो चालू करना, जो भी हम ट्रीटमेंट का प्लानिंग है उसका कॉस्टिंग पेशेंट को बताना है, उनको फाइनेंसेस अरेंज करके रेडी रखना है. और सर्जरी और फर्टिलिटी का दोनों का इट शुड बी कॉम्प्लीमेंट्री. इट शुड बी लाइक यू हैव टू गो हैंड इन हैंड और सक्सेसिवली. यू कांट गिव अ ब्रेक. only then the chance of pregnancy, only then the chance of success with infertility treatment will be maximum.
Right, ma'am. So, from the patient perspective, they generally the mindset is, since I have undergone an endometriosis surgery, most of it is cleared within. I may have a chance of getting pregnant naturally, and so then the tendency is to delay the fertility treatment. And by the time she delays it, she may again, have problems in conception. So the ideal thing is to plan both when the patient has come for both the pain management of endometriosis and infertility. At that time, the surgery and the infertility plan, infertility treatment should also be taken hand in hand, and finances should be counseled accordingly so that patient is mentally prepared for undergoing the entire plan, which is comprehensive. Very nicely explained, ma'am, in a very, very simple language. One more question that we have is, what are the risks of this surgery?
तो ये जो एंडोमेट्रियोसिस रहता है उसमें ग्रेडिंग रहता है, ग्रेड 1, ग्रेड 2, ग्रेड 3, ग्रेड 4. तो सबसे सिंपल है ग्रेड 1, सबसे सीवियर है ग्रेड 4. तो ग्रेड 1, ग्रेड 2 में इतना क्या भी वो रिस्क नहीं रहता है. जो कॉमनली एनेस्थीसिया का रिस्क रहता है, जो कॉमनली हम जो सर्जरीज करते हैं लैप्रोस्कोपी का जो रिस्क रहता है, सिर्फ उतना ही रिस्क एंडोमेट्रियोसिस के सर्जरी में भी होता है. लेकिन ग्रेड 3, ग्रेड 4 में क्या होता है, वो इंटेस्टाइन चिपका हुआ रहता है और ब्लैडर जो चिपका हुआ रहता है, यूरेटर जो हम बोलते हैं वो ट्यूब, तो वो भी चिपका हुआ रहता है. तो ये सब का डैमेज होने का चांस रहता है. तो हम ये सर्जरीज जो करते हैं वो अगर हमारा इतना ट्रेनिंग नहीं हुआ है तो हमको सीनियर डॉक्टर या जो भी डॉक्टर है जिसका इतना एक्सपीरियंस ज्यादा है एंडोमेट्रियोसिस में, उनको लेना पड़ेगा हेल्प के लिए सर्जरी के टाइम में. और पेशेंट को हमको बोल के रखना है कि ये प्रॉब्लम हम फेस कर सकते हैं और ये कॉम्प्लिकेशंस का रेट 1 to 5% रहता है. अगर कॉम्प्लिकेशन हुआ तो भी उसको हम मैनेज कर देते हैं. और मोस्ट ऑफ द कॉम्प्लिकेशंस कैन बी आइडेंटिफाइड ड्यूरिंग द सर्जरी एंड इट कैन बी टैकल्ड एट द सेम टाइम. सो यूजुअली जो सर्जरी का स्टेप्स जो रहता है वो सब स्टैंडर्ड स्टेप्स और सिस्टमैटिकली हम करें तो वो रिस्क जो रहता है इट इज लेस देन 1% according to me. So I think if it is done by a good advanced laparoscopic surgeon, then the safety of the patient will be maximized.
Right. So, ma'am, we would also like to understand what happens if the patient keeps on postponing the surgery, or may even decide not to get the surgery done. What are the complications related to that?
See, mostly it is that symptoms will keep getting worse. One. Second thing is the cyst also keeps growing. जितना जिंदगी में उनका पीरियड्स का जो टाइम रहता है, मतलब 45 या 50 इयर्स तक जिनका वो पीरियड का टाइमिंग रहता है, मंथली पीरियड आता है, तब तक सिम्टम्स तो रहते ही रहते हैं. तब तक ये सिस्ट बढ़ता ही है क्योंकि वो हार्मोन्स अंदर रहते हैं बॉडी में. तो इसीलिए ये सब सिस्ट वो हार्मोन डिपेंडेंट रहते हैं एंड इट विल कीप इंक्रीजिंग इन साइज. द बिगर द साइज, more the complications during surgery. The bigger the size, the more the symptoms many a times. The bigger the size, more that it can cause injury, cause problems to the kidney, cause problems to by pressing on the ureter, cause problems by rupturing, cause problems by getting infected, cause problems by bleeding inside. So all these problems can be expected. And tackling these problems in an emergency situation is not easy. अगर समझो कि पेशेंट को 5 साल से पता है उनको 6 सेंटीमीटर का सिस्ट है, लेकिन अभी उनको वो सिस्ट 10 सेंटीमीटर हो गया है और उनको सडनली एक दिन वो सिवियर पेन, सिवियर ये ब्लीडिंग ऐसा वो आ गए इमरजेंसी में, तो वो लैप्रोस्कोपी करने का जो रिस्क रहता है वो बहुत ज्यादा रहता है क्योंकि कोई भी प्रिपेयर नहीं रहता है उसके वो टाइम पे. तो these are the things which can be managed easily if it is done electively. मतलब हम फिक्स करके पहले से ही पेशेंट को बता के ऐसा होगा और हम भी प्रिपेयर होंगे, तो तब हम करें तो chances of complications will be very less. So that the patient has to understand. And these are not cases where things will improve magically by itself, naturally. मतलब ये नहीं है जो सिर्फ वो अगर हम 6 महीना रुके 1 साल रुके तो अपने आप से वो पिघल नहीं जाता है, उसको ऐसे ही वो रहता है. So that we have to keep telling the patient that it will not get better if they take Ayurvedic treatment, homeopathy treatment, if they take Herbalife, if they take like all nonsense that they take, even if they take the Sanjeevani water also, it is not going to get better. It is very, very, very important that it is supposed to be cleared by surgery only.
Got it, ma'am. Got it, ma'am. So now since they know that earlier they get it treated, the better it is for them. And since the beginning, I understand that this is the only thing that you have been trying to say, that you can get better with it if you are getting it operated and do not have, major complications if you are going to the right doctor. मैम आपने बताया कि स्टेज 1, स्टेज 2, स्टेज 3, स्टेज 4 होता है और पेशेंट्स को जब फर्टिलिटी, आज हम फर्टिलिटी एंड एंडोमेट्रोसिस के बारे में बात कर रहे हैं, तो उसको साथ में फर्टिलिटी भी प्लान करना है. तो most of the patients would also like to know here that when you are talking about getting it operated from a good surgeon and then planning your fertility treatment, and each of these stages, how are the costs involved?
See, I practice in Bangalore. Bangalore is a metro city, and I practice in a little upscale market, as in like people are all software engineers and they all are like quite well settled. And I get patients from mostly middle class and upper middle class. So I can only tell my experience. So I have been practicing from past 18 years. In grade 1, grade 2, majority of the times, if the clearance is done very well, then usually they conceive only with simple ovulation medications and sometimes IUI. So each IUI, we charge around 8,000 rupees and medications in that cycle will be around 3,000 to 4,000 rupees. So everything included, it will come within 12,000 to 15,000 rupees. Depends on the age of the patient also as to how much dose they will require. If it is grade 3 and grade 4, then for the surgery, we usually charge around anywhere between 1 to 1.5 lakhs. And post that, the IVF that costing we have at this moment is around 1.7 to 1.8 lakhs, including the medicine. And
Right.
most of the times, our clientele that I have, so they are all like more than 33, 34 years of age, and they are all like career women who have delayed marriage, who have delayed pregnancy. So AMH will be less, or they will have male factor involvement also, where the sperm count will be less. So in such situation, I have found that the most cost-effective treatment is IVF only, in spite of thinking of it as a very costly treatment. But the success is better, and also we can address many other associated problems which are there, and the patients can have a better take-home baby rate than like keep trying with simple medications, doing multiple IUIs. So that usually is what I have found.
Right. Thank you so much, ma'am, for the clarity. Dr. Dipesh, we have known the rates across, the area in Bangalore. We would also like to understand how the rates are there in the west part of the country.
So like Madam told, whatever the clientage, like in that all are career working couples and they're likely to be delayed the pregnancy. We are in Ahmedabad, same category of patients now we have. Our IUI charges are typically same 10 to 15,000 because it's very simple process, and but have the limited success rate with limited case selection cases. IVF charges typically we have around 1,25,000 to 1,75,000 depending on the patient age, AMH, and type of treatment. Yes. Laparoscopy charges are typically good surgeon that are similarly like that. But similarly, whatever the crowd in the Bangalore, like whatever the lifestyle that happen in the metro city, now they are coming up to the in Ahmedabad nowadays.
Right, sir. Right, sir. Right, sir. Right. Ma'am, a lot of patients, when we explain them, especially when I shadow a doctor explaining a patient on endometriosis across this 10 to 12 years of experience in infertility. Coming out of a doctor's chamber, they really don't feel good. And they feel like, it is a major surgery and how am I going to tackle it? And can you show some insights to these emotions? How can patients manage their emotions? And is it really a major surgery?
The endometriosis or the IVF, you mean?
Endometriosis surgery.
Surgery, yeah. See, the thing is, it depends on whether you are a laparoscopic surgeon yourself or not, one. And second thing is like in your career, how many cases have you managed successfully in endometriosis? So these two things will play a very big role in counseling the patient with confidence. See, we should be confident in treating it, only then the patient will be confident. If we keep telling that, oh, it may come back 50% of the times, oh, it is very big, we may cut your ureter, we may cut your kidney, we may cut your bladder, then nobody will be happy. The first thing is we should know as to how confident we are about our surgery, or if we are taking a help from some other surgeon, we should know how competent that surgeon can do it. See, if somebody like Dr. J is coming and operating, now I give a blanket sentence saying that, come, we will do it, don't even worry. You just come for the surgery. So I will take the complete responsibility. Whatever happens, I am here to practice for the next 30 years. I will take care of you for the rest of your life. So the patient kind of like, gets that confidence. Okay, I mean, if she is telling it so confidently, then it must not be so bad. Even if it is a major surgery, they are quite well equipped in dealing with the problems. And I can tell you confidently on this forum that Indian surgeons are one of the best surgeons in the whole world. And also because Indian surgeons get a lot of cases to do, one. Second thing is they are very, very hardworking. So they work hard from the time that they have started their MBBS. So they put their sweat and blood into it and they keep working for the better skills to acquire for the better patient care. And what the patient should get when they consult and go out is, yes, I mean, I want to get better. I want to get better by getting the surgery done. And I want to get the surgery done from this doctor because this doctor knows what she is doing, he or she is doing. So when we kind of like, give that confidence to the patient, so the patient will be very comfortable. See, I am telling you on Thursday, we will be operating with Dr. Jay Mehta in Bangalore. And we have around 21 cases posted for just 2 days, 1.5 days. And in that, majority of them are endometriosis. It's not that there is nobody else doing it.
Very nice, very nice.
Yeah, so it is about the confidence in which we are telling the patients, yes, he's the best in India. You please come, you do it, you will get better. The IVF success will be better. Your pain will be better. You will have a good relief with whatever problems you are having. So it all depends on how you take the patient into confidence, because you should be confident before you give that confidence to the patient. If you are shaky and if you are not comfortable, then obviously the patient will take the same message and say that, oh, I'll come back next month, I'll come back after 3 months, I don't have the money, my mother is not there, my father is not there. So a lot of things will keep coming. My children have exams, I will come back in Dasara, the holidays or summer holidays. So it keeps like, they'll keep giving reasons. So you'll have to make it like short. Yes, you have to do it. You have to do it. If the patient is listening to you, then she will definitely come back. If she doesn't listen to you, if somebody says that, no, take this injection for 1 year, take this tablet for 2 years, then it is their problem. But what is the right thing? That is what you have to do as a doctor. What is the best for the patient?
Right. So, ma'am, you have actually given us a one-line answer saying this, that the anxiety of your patient is as anxious as you are.
Yes.
So if you are not anxious, probably this feeling of patient coming out of a doctor's chamber, it depends completely on how you manage and how you counsel and show them the confidence that everything is just going to be okay.
Yes.
And this confidence is the confidence with which the patient will come out and will be happy. Very nicely explained, ma'am. Very nicely explained. Last question is to Dr. Dipesh. Sir, just tell us that if a patient having endometriosis, getting operated endometriosis and post that she has gone for an IVF treatment versus a patient who did not have an endometriosis and have gone for an IVF treatment, how are the success rates different?
So, after operating the endometriosis, especially for the large and chocolate cyst, the outcome would be the better. It's improved the eggs quality, it's improved the implantation rate. Sometimes adenomyoma, those was the uterine endo thickening, that in focal adenomyoma, we remove that thing and that improves the implantation and pregnancy rate. So it's not that all endometriosis cases have to be operated before IVF, but those who are needed, they have the better IVF outcome after operating the endometriosis cases.
Right. Shilpa ma'am, and what are the chances of pregnancy post endometriosis IVF is done, if IVF is done?
No, it depends on various factors. See, if it is endometriosis only is the reason, then the patient will have very good success rate with the good clearance, which is about 35%, which is standard all across the world. But if the patient has low AMH, if the patient has, the husband has low sperm count, and if the uterus has multiple fibroids, or if there is a problem with the endometrial lining, if there is infection in the uterine cavity, then obviously the success rate will go down by 5%. So roughly about 30 to 35% is the success rate if the clearance is done and if the IVF is done within 6 to 8 months of the surgery.
Right. Thank you so much, Dr. Shilpa and Dr. Dipesh. Today we had wonderful insights, probably most of the questions starting from what is endometriosis to what are the outcomes of IUI, IVF and other indications. Thank you so much, all our viewers here, and stay connected with us on our channel. I am Dr. Mala. On behalf of Dr. Shilpa and Dr. Dipesh, thank you all for joining here, and stay connected with us for more such lovely insights. Wish you all the very best. Don't worry and just follow doctor's advice. No matter what you have, there is always hope. Thank you. Namaste.
Thank you. Thank you. Thank you.